Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Kieran Mir-Hudgens. Today's episode features expert discussion of the burden of HBV disease in the U.S., as well as barriers to screening, evaluation, and treatment, particularly among foreign-born immigrants. This episode is part of a larger educational program titled Tackling Racial Disparities in Care for HIV and Viral Hepatitis. During this podcast, Dr. Mindie Nguyen from Stanford University Medical Center and Dr. Lewis Roberts from Mayo Clinic will discuss key data on barriers to care among persons living with HBV in the U.S. and strategies for overcoming these barriers, including expanded research into health disparities and community-based solutions with culturally appropriate interventions. For more information on Dr. Nguyen and Dr. Roberts, along with a link to the complete program, including a downloadable slide set, please visit the show notes for this episode. Now let's get started and hear what the experts have to say on this important topic.
Hello, everyone. I will start the program next on HBV. So first, we'll review the HBV disease burden. Globally, about 290 million people affected by hepatitis B. And the important point here is that only about 10% so far have been diagnosed according to a recent estimate here, and only about 1.6% are receiving antiviral therapy. So we do have a very major problem with the care cascade for hepatitis B. In the US, we estimate that hepatitis B prevalence is only about 0.35% in the general population. But because 2/3 of the hepatitis B in the US are foreign-born and the majority are Asian, we have a disproportionate higher number or prevalence of Asian and non-Hispanic Blacks with hepatitis B, 2.74% for Asian and 0.64% for non-Hispanic Black. So I would like to review the more specific examples of the barriers to different stages of problems with this care cascade. And before that, I also want to bring up an important point is that while you can see from this California Cancer Registry data that Asian and Pacific Islanders have about twice or higher the rate of cancer compared to other ethnic groups, there is great heterogeneity within the Asian communities. So you could see the Southeast Asian groups here, the Vietnamese, Cambodians, and Laotian, their rate of cancer actually is 2 to 4 times more than other Asian groups. So this is very important to keep in mind while you care for the Asian communities, depending on which subgroups of Asian communities that are prevalent in your community. And as mentioned earlier, we do have problems with the care cascade and practically at all different levels here. And I would like to go over some of these examples and identify the areas where we can improve. So this is recent data using the TruVan database, which includes more than 150 million US people with private insurance. So we assume that these people have relatively better insurance coverage than the general population, and it covers almost half of the US population with more than 150 million people. So using this, and we identify 95,000 people have been diagnosed with HBV, and comparing this against the true prevalence or burdens of hepatitis B from our epidemiologic survey, the NHANES data, and we section stratify this by the US Census Bureau, we estimate that only about 18% of hepatitis B people in the US have been diagnosed. We also looked at treatment rates. And even when you look at people with more advanced disease like cirrhosis, only 1/3 had evidence of any antiviral therapy at all. And even among HCC patients, only about half. When most or vast majority, if not all of these patients with cirrhosis and HCC should be on antiviral therapy. The disease awareness among Hep B patients is also about 15% according to our epidemiology survey. So the data from epidemiology survey and also from real-world data from insured people who have reasonable insurance coverage are fairly consistent that only about 15 to 18% have been diagnosed. We also found, disturbingly, that even among the people who have been diagnosed and linked to care, meaning that they are in care with a primary care doctor and or even people in liver university clinics or community GI practices, only about a third of the primary care patients and only half of the community GI patients and only 80% of university liver clinics patients receive what we consider to be adequate based on very minimum requirement to be adequate here, just an ALT, E antigen, and HBV DNA. So as I mentioned earlier, in the large database ensure patients, we found that only about half of the patients with HCC have received antiviral therapy. Now, big databases includes large number of patients, 150 million people, but it may have inaccuracies in coding, etc. But the data is actually quite consistent with this data where each patient's records was manually reviewed. And this is a collaborative study that was performed with patients from Taiwan, Korea, and the US, including patients from Stanford and Mayo Clinic in collaboration with my co-faculty today, Dr. Louis Roberts. And we found that patients with liver cancer, with or without cirrhosis, only about 17% of them have received antiviral therapy by the time of HCC diagnosis. And even after HCC diagnosis, only about half received treatment. This is quite eye-opening to me personally, that these are the patients receiving care at tertiary care center, and the antiviral therapy treatment rate is still really way below what it should be. So much work needs to be done here. And also consistent with what we saw in the private insurance database study, the financial difficulties here actually was only cited by chart review by either physician or patients here. It's only a minority of the cases for the lack of treatment in hepatitis B patients. Most get lost to follow-up. Many cases, either the patient and or the doctor wanted to observe the patients more. So financial issues, difficulties is definitely an important factor, but it's actually only in a minority of cases, at least in the patients who are already in care. So we need to look beyond financial problems, provider education, patient education, system changes to make it easier for patient and doctor to adhere to treatment guidelines. Another recent study also looking at insured patients here. So the data I showed earlier was looking at patients from primary care and GI practices in the San Francisco Bay Area. But this is a nationwide database covering the whole of US, and everyone had private insurance. And this is from 55,000 hepatitis B patients. And unfortunately, we found pretty similar results. So you could see here that the percent of patients who get ALT, DNA, E antigen are not anywhere near 100%. So if you require ALT, DNA, and E antigen, then it would be consistent with the fact that only about a third of the patients, 33% here of the patients who did not have specialist visit had adequate evaluation. The number is a bit higher, 40%, 43%, if the patient was seen by a GI or an ID physician. And we found that the rate for evaluation and testing are better in patients with liver cirrhosis or compensated or decompensated, but it's still not anywhere near 100%. The number of patients who undergo HCC surveillance here is also only about half, not even in patients who are seen by GI ID specialists. So again, so much more needs to be done. Access and financial coverage is important, but beyond that. And this highlight what I already mentioned in higher view here for HCC surveillance. So you could see in patient with compensated cirrhosis here, only about half of the patients had HCC surveillance, and it should be 100%. So much work is to be done. This is older data, but this is a large sample of Asian Americans in the San Francisco area, show that only about the prevalence here is about 9% of the patient who had disease, but 65% of patients were unaware. So again, we found consistent data, from private insurance, nationwide large databases, to a community survey like this study, to our formal epidemiology survey throughout the US, the enhanced data. The patient awareness is nowhere near 50% or 100%, only about 20-30%. And not all patients diagnosed are linked to care. So this is results of a study for Vietnamese patients, sample from 7 different locations and healthcare fair events in California. And these patients receive their diagnosis, they get counseling by phone by the study coordinators, and they get called back 6 to 9 months later to check to see if they have seen a doctor for it. And in here, we could see that only about 32% have been seen by a specialist 6-9 months later, and only 63% have seen a primary care doctor for their hepatitis B. So we have problem with screening diagnosis, and then the patient also are not linked to care. And among people who are linked to care, they do not get adequate evaluation. And if they don't get adequate evaluation, then how do we know that the patient meet treatment criteria? And even advanced patient, HCC cirrhotic patients, only 1/3 to 1/2 receive treatment. So problem with every single step. Now, one of the major problems or barriers to care that I have been alluding to, that is beyond financial concerns, some of it patient education, provider education, but also culturally appropriate approach to patients. 2/3 of the Hep B patients in this country are foreign-born, from Asia, from Africa. So these are patients who come from very different areas with different cultures. So it really requires cultural appropriate approaches. For example, in hepatitis B and Asian, for Western medicine, we think of treatment is mainly antiviral therapy with these treatment here, either injection or pills. Whereas in the Eastern medicine, the approach tend to be more holistic and alternative medicine, herbal medicine, chiropractic treatment, yoga, the yin-yang balance. So many other things could be considered or in our discussion with the patient. So maybe we can get better acceptance to treatments and recommendation. So with this, I will turn to my colleague, Dr. Louise Roberts, to review the barriers and what we should learn for our African immigrants.
Thanks very much, Professor Nguyen, for this wonderful introduction to this topic. I'll now discuss some more relating specifically to African immigrant communities and some of the barriers to care for them and potential solutions that we can institute to mitigate some of these barriers. First of all, Dr. Nguyen had told us at the beginning about the preponderance of hepatitis B virus infection in immigrants, either from Asia or from Africa in the United States. And she mentioned some information, particularly about non-Hispanic Blacks, that overall, there's about a 0.64% prevalence of chronic hepatitis B virus infection. And this is what the rate is in the immigrant population compared to the US-born population, where it's about 0.52%. So looking at that number, one would think that's a relatively low proportion of individuals of African ancestry. However, it's important to recognize that within that broad, large group, there are a number of subgroups that have substantially higher prevalences of chronic hepatitis B. And I think that's one of the first messages for us as physicians and as providers is identifying within the communities that are closest to us what the prevalences are of chronic hepatitis B. So this is an example of a study that we did here at Mayo Clinic where we identified all the immigrant Somalis that had ever been seen here at Mayo Clinic. And so since about 1990, when they had the Somali Civil War, we've had a substantial number of Somali immigrants that have come to Minnesota. And what we found was that of the individuals that had been seen at Mayo Clinic, we actually had about 3,000 individuals that had been seen at that time. About 700 of them had been tested for either chronic hepatitis B or chronic hepatitis C. And of the ones tested for chronic hepatitis B, you can see the frequency of chronic hepatitis B here on the left, where in the Somali community, you can see on average, when we did an age-adjusted calculation, it was about 12%, so about 120 per thousand of the individuals that were tested that were positive for chronic hepatitis B. So that 12%, of course, is quite a bit higher than the 0.64% if you take all immigrant Africans across the country. So it's really important to identify what the rate is in the community where you are working. So the next thing that I wanted to highlight is that it's really important to identify those individuals who have chronic hepatitis B who are at risk for liver cancer and should be enrolled in surveillance for liver cancer. And this is an interesting study that we did again at Mayo Clinic, where we looked at all individuals with cirrhosis who were undergoing some frequency of surveillance for liver cancer. And we asked the question, how frequently is each patient getting their surveillance compared to the standard recommendation, which is surveillance using ultrasound and alpha-fetoprotein measurement every 6 months. And what we did here was we reported here in this graph the percentage of surveillance. So you can see here 100 people who were getting 100% surveillance were 14% of the group. That is over a 2-year period. They had surveillance 4 times over the 2-year period, every 6 months. On the other hand, 30% of the group had at least 75% surveillance. So it includes this group that had 100%, but an additional, about 15% of individuals only had 3 out of the 4 surveillance tests. And then here we have 50%, and those are people who had at least 2 out of the 4, and so on. But what this tells us is that ideal surveillance is only being done on about 15% of our population. Now we ask then, what are the factors that are associated with higher surveillance? And it's really interesting. If you were seen by a specialist, you were much more likely to have surveillance that was ideal. But also, if you had advanced liver disease, and Dr. Nguyen actually mentioned that in one of his slides as well, the idea that if you had either compensated or decompensated cirrhosis, you were more likely to be under surveillance. And then finally, also, if you had a comorbid illness, such as diabetes, you are more likely to be under surveillance. Interestingly, age, sex, race, residence, cirrhosis etiology, or the number of primary care visits you had did not significantly affect the rate of surveillance. This brings us to what I term the immigrant paradox. When we looked at the outcomes of patients that were in the immigrant Somali community compared to the outcomes of the general non-Hispanic white community, what we found was that the outcomes were similar. However, we noticed that the Somali community actually had better health overall. They had less advanced liver disease. They had fewer comorbid illnesses. And so one would have expected actually that they would have had better outcomes than the general population. However, on the other hand, we see that they had fewer specialist visits and they almost always had delays in starting treatment. So this resulted in more advanced HCC diagnosis and a poor outcome for their health stage. Overall, given their better health, we would have expected them to have better outcomes, but their outcomes were only equivalent to the larger population. So this takes us back to what's happening with HCC in Africa, because our African immigrants, of course, are coming from Africa, and they, in a sense, bring with them some of the risk factors that they have acquired in Africa. And one of the things that's important to note here is looking at the different WHO regions of the world, we can see that the African regions, Northern Africa, Western Africa, Middle Africa, Southern Africa, and Eastern Africa, all have relatively high incidences of hepatocellular carcinoma, particularly in Northern, Western, and Middle Africa. And this is in part the case because Africa lags behind in a lot of the primary public health measures that we use to reduce the burden of chronic hepatitis B in populations. And perhaps the key one in which Africa lags behind is in the hepatitis B birth dose vaccination, where you can see there has been initiation of the birth dose only in approximately 11 of the 50-odd African countries shown here. So the countries in yellow are where the hepatitis B vaccine birth dose has been introduced, and the countries in the orange are where there's hepatitis B in the later on childhood immunization schedule, but not in that the birth dose has not been administered, is not being administered, and that's in the majority of the African countries. So the other area in which Africa lags behind is in HBV diagnosis and treatment. And we can see here, in terms of, in the blue bars, the percentage of hepatitis B infected persons diagnosed up to the end of 2019, and the red bars, those treated to the end of 2019. You can see here that only 2% of individuals who were hepatitis B infected in the Africa region had been diagnosed by the end of 2019. So only 1 in 50 people knew that they had chronic hepatitis B, and only 0.1% of the hepatitis B infected individuals were under treatment. So really lagging behind in diagnosis and treatment. So as individuals come to form communities here in the United States that are African immigrants, that's the background that they're coming with. There are certain other unique features of hepatitis B in Africa that are worth mentioning. First, most transmission is horizontal. In contrast to what happens in Asia, where a lot of transmission is vertical from the mother to the child at the time of birth, about 10% of transmission in Africa appears to be vertical, but most of it occurs after birth, but before the age of 5. In Western Africa, particularly, hepatitis B genotype E is the most prevalent genotype, and in East Africa, genotype A1. Both of these genotypes are associated with lower levels of replication of the hepatitis B virus. And so patients often have low replicating virus and typically do not meet criteria for treatment. Many of these criteria having been determined based on data from Asia, where people tend to have higher viral loads. However, despite the fact that they have low viral loads, the hepatitis B virus that they have, these genotypes appear to be more oncogenic than would be expected based on the low HBV DNA levels. And consequently, we see that hepatitis B virus-induced HCC occurs at a relatively younger age in these communities than in other countries and regions of the world. So to highlight, only a small minority are aware of the hepatitis B virus infection. And the consequence of this is that they are not undergoing surveillance. And so most HBV-induced HCC are diagnosed at terminal stages. And in one study that we did, we found that over 95% of liver cancers were diagnosed at a terminal stage where no treatments could be offered. So in one of our network studies for the African Network for Gastrointestinal and Liver Diseases, we did a study of the age of onset of liver cancer in Africa. And so we did this study in 8 different African countries and of 1,520 patients. And what you see here is that for hepatitis B virus-induced liver cancer, the median age of onset was about 42 years. And you can see that the preponderance of these patients, about 2/3 of them, were aged between about 32 and about 55. So these individuals are very young at age of diagnosis of liver cancer. And it's interesting then to look in the United States. So this is US SEER data from the Surveillance, Epidemiology, and End Result Study gathered here in the United States. And what we've done is we've plotted the percentage of individuals who were under the age of 50 at the time that they were diagnosed with liver cancer in the United States. And what you see here is that individuals born in Africa, but living in the United States, in the Western Africa region, more than 50% of these individuals were under the age of 50 at the time of their liver cancer diagnosis in the United States. And then if we look at other parts of Africa in this sort of Western to South Central to Southwestern region, you can see again, it's about between 30 and 50% of individuals that were under the age of 50, even when they were diagnosed in the United States. So these African immigrant communities can reflect different socioeconomic and cultural dynamics of their home countries. And I'll just highlight a few of these. One is that there's a substantial social stigma that's associated with a hepatitis B diagnosis. And so this leads to secrecy. And this is partly related to the fact that there's a high value that individuals place on community acceptance. So if they are concerned that they'll be stigmatized and excluded from the community, there tends to be secrecy about their diagnosis. Access to care also is often related to their socioeconomic insurance status and the social geography of the access, the sort of physical distance between a site where they can get good care for their hepatitis B and where they are living. There's also somewhat of a general suspicion of Western medical systems and whether Western medical systems are truly beneficent, are truly wanting to do them good rather than harm. And Dr. Nguyen mentioned this as well, that this idea that culturally people may prefer spiritual, traditional, or alternative medicines to Western medicine. Dietary patterns factor in as well. And we know, for example, that the diets in Africa expose people to aflatoxins, where there's fungal contamination of grains such as maize, corn, and peanuts that leads to ingestion of this toxin that causes mutations in DNA and predisposes people to liver cancer. We find also that some communities have an aversion to invasive procedures and surgery. Some communities are very stoic and are less likely to express distress even when they are ill. And we see what we call smiles in the face of discomfort. People have grown up in circumstances where they have to be very resilient. But what it means often is that they are less likely to complain when they are ill. Other barriers include lack of insurance, concerns that their legal immigrant status might be jeopardized if they are seen in a healthcare setting. There's limited healthcare awareness, as Dr. Nguyen has mentioned, and there's language and cultural barriers, and a sense that people don't pay as much attention to their personal health because they are focused on others, sometimes people who they've left behind in their home countries. So what are some of the solutions to overcome these barriers to care? And I think it's important to recognize that research actually can play an important role in this. And in some ways, research can either contribute to disparities if it's done wrong, or it can help address disparities if it's done right. So, for example, certain genetic differences may not in themselves cause disparities, but a lack of appreciation of their functional relevance can. So there's, for example, differences in the way people metabolize different drugs. 5-fluorouracil is a common drug that's used to treat colon cancer, for example. And their populations and their higher rates, for example, of people who have low levels of the enzymes that metabolize this drug in their liver. And so consequently, they're more likely to have side effects if you treat them with the drug. And it's important to recognize that we need to be looking out for these changes. There's also a lack of trust sometimes that impairs participation in studies. People often ask you, are you going to make a guinea pig of me? And this is in part due to some of the history of research that's been done on underrepresented and disadvantaged communities. We mentioned the geographic exclusion, that people sometimes are distant from the academic medical centers. Sometimes complex medical jargon inhibits their understanding and their willingness to participate. And people who are working health professionals and providers in low resource settings may have limited time or resources for research. But it's important to include their communities in research, because then we can develop the best strategies for helping these communities. So finally, in this section, it's important to engage communities, to include both the participants and the healthcare professionals and researchers in discussions of research. One of the keys we've identified to community participation in research is a process for return of research results, telling people what you found when you do the research so that they can feel that they were included in the research process. It's important to address community awareness of the disease so we can help reduce the stigma and silence. And it's important to advocate for structural change in our medical and civic institutions so that we make these things normative. We make research a normative part of the care of patients. It's important to realize that community leaders and institutions can be trusted partners by providing health information and increasing health awareness of the positive outcomes of science-based medicine. So next, what are some of the health system-based strategies we can use to address hepatitis B disparities? I think first, from the perspective of providers, compassion and genuine concern for our patients is key. This takes effort, it takes self-awareness, and it takes time. It's important to normalize the illness to reduce stigma. As we've mentioned, to improve access to insurance and reduce the fear that people have of deportation if they do not have legal status. To address the suspicion of the healthcare system, and an important part of this is increasing the diversity of the healthcare workforce and recruiting culturally congruent patient navigators to help patients. And then, because of the concern about invasive screening and treatment, it really helps to be developing techniques such as blood biomarkers, fibroscan elastography, and other treatments that are considered as less invasive by patients. And now we'll go to a patient's description of their own experience for the patient perspective.
Yeah, I've had one provider, which was my primary care at the time. She was relatively new doctor, and I noticed that when I would go see her, she really wasn't knowledgeable about my condition, and she acted as though she really didn't want to treat me. I only had her for maybe a couple of weeks, and I switched doctors so I didn't feel comfortable with her. She was just cold. And me and my doctors, I have a very close relationship with all my physicians. And this was the first one that I had that really didn't take the initiative to treat me. And I asked other patients who she's seen, and they've had no problems with her. But of course, they weren't gay, and they wasn't my skin complexion. So right there, I was like, I need to change doctors because I didn't feel comfortable with her, and I felt that it was a little, she didn't too much care for African Americans. Well, I think that all clinicians should be knowledgeable of all of the, diseases out there, such as hepatitis B and HIV. They all should have especially ones in rural areas, because there's, in rural areas, there's not a lot of specialists especially for hepatitis B, let alone hepatitis B and HIV co-infections. And so I think every doctor should be mandatory that every doctor be knowledgeable of all those conditions and diseases, so that they can treat patients fairly and patients aren't left out in the dark, trying to scurry and find, adequate health care, because it shouldn't be, a gamble, because that's basically what it is, a gamble on a patient's health when they can't find a specialist who specializes in their condition. Either there are doctors that won't treat them because they don't know about it, and there are doctors that will treat them, but they won't reach out and ask other specialists in the larger cities how to treat a patient with this condition. So I think every doctor should be well-versed on hepatitis B and HIV and various other conditions.
So hopefully we'll be able to discuss that some more in the discussion time. But one final thing to mention is the importance from a provider's perspective of doing those things we can to increase the proportion of our patients who know their hepatitis B status. Because, of course, that's important for getting people into the key linkage to care. And this is one study we did where we actually sent providers a reminder when they were going to see someone who was born in a high prevalence country. The week before the visit, we sent providers a reminder to remind them that this person had never been tested for hepatitis B, that we could tell, and to have a discussion with the patient. And we examined the control period 6 months before the intervention and the intervention period, which was about a 6-month period. And you can see here, we had about a 4-fold increase in screening rates of people born in high-risk countries or high-prevalence countries using just a relatively simple intervention of physician reminders. So I'll pass this back to Dr. Nguyen.
Thank you, Dr. Roberts. So in the last hour, we have presented to you the various barriers ranging from financial to geographic, social, isolation, to access to care, to cultural stigma, etc. So we would like to wrap it up and also summarize some proposed solutions that Dr. Roberts also have touched on several. So we had to start from vaccination and screening. So we had to start with primary and secondary prevention. So primary prevention with vaccination, as Dr. Roberts just mentioned in the last slide, we need to find not just individual like patient and provider education, but we also need to help our patients and providers with system changes, such as electronic reminders or whichever ways that would be most feasible and appropriate for the specific communities so that we can increase screening and vaccination. So at-risk individuals, pregnant women, etc. And then once a patient is diagnosed, they need to be referred to care providers, whether a primary care doctor or a specialist who are familiar and comfortable with treatment of hepatitis B patients. The audio clip really illustrated that it is important for the providers to feel comfortable and familiar with hepatitis B management so that patients can feel comfortable in following the recommendation of that physician. physician or providers. And then disease management. The patient needs to get proper monitoring because hepatitis B is a very dynamic disease. One patient may present with relatively inactive disease, but that can become active during the course of the disease and that patient follow-up. HCC surveillance, both Dr. Roberts and I have shown you the data in different populations and communities. It is really, really suboptimal. It's well less than half of the patient with hepatitis B having any significant or reasonable surveillance. And treatment rate of the patient who are treatment eligible. So this is one area that is still in development because guidelines for hepatitis B in the US as well as overseas, there's a lot of patients fall into the gray zone that don't really fit into any of these criteria. And also there's a lot of confusion and differences among the guidelines that cause many confusions. So this is one area where there can be system changes so that the screening recommendations, the treatment recommendations can be simplified so that it can be more feasible and more accessible to more patients. And even the patients who are already in care and on treatment, there are data to suggest that many of these people do not really follow up long-term and do not stay on treatment long-term. So retention in care and treatment is another important aspect of care that must be emphasized. So a few key take-home points for us is that the majority of Hep B patients in the US foreign-born, and the majority of these are from Asia and Africa, but there are also a large number of patients from parts of South America, Central America, Eastern Europe as well. The unfortunate thing is that only about 20% or less of hepatitis B patients in the US have been diagnosed, and the majority does not undergo optimal evaluation, monitoring, and even the patient with advanced disease or those meeting treatment criteria, they do not really receive treatment. Only 1/3 to 1/2 of people with really severe forms of liver disease, cirrhosis and HCC get treatment. So there are many barriers and we just review and potential opportunities for improvement that need to start with the individual provider as well as community and healthcare system. More simplified and practical screening and treatment algorithm is really needed. With this, we'll go to the question and answer session, and I would like to turn this to our moderator.
Well, thank you so much, Dr. Nguyen and Dr. Roberts, for that excellent presentation, and it was so valuable. Unfortunately, we don't have a lot of time left, but I do want to get to a couple quick questions. First of all, I want to pose to the doctors an opportunity to follow up very briefly to our patient video. What can be done to empower patients to choose a different provider if they don't feel like they have a therapeutic relationship? And how do we help train providers to avoid the kind of bias that Mr. Crum was sensing?
So I think a key element here is the whole topic of cultural competence. Mm-hmm. And sort of thinking about that is as partly the knowledge and interpersonal skills that allow providers to understand, to appreciate, and to work with individuals from cultures other than their own. So it involves sort of a self-awareness and acceptance of cultural differences, understanding that others will have differences in their cultural mindsets, being willing to know the patient or colleague's culture, and being willing to adapt or develop the adaptable skills to best address the needs of the patient. So I think those are really key from a provider perspective.
Thank you, Dr. Roberts. And because we're short on time, I'm just going to make a few audience comments rather than phrase them as questions. Jude from our audience wants to mention that we really could learn a lot from the HIV world in terms of undetectable equals untransmittable. And she feels strongly that we should empower patients to have vaccination and treatment so that they don't need to negotiate that in their relationships. So thank you for that, Jude. And also, Claudia wants to mention to the presenters that this was an excellent presentation, and are there downloadable slides? And yes, they will be available on the website. So let's have time for one more question. This one is very specific about horizontal transmission in Africa, and what is the mechanism of that?
That's a great question. And it's not completely clear. There's been a number of epidemiologic studies that suggest that if individuals, children, grow up in a household where there are other hepatitis B positive individuals, they are much more likely to become hepatitis B positive. There are practices that have been described, such as, for example, sharing of utensils that are used for dental hygiene, for example. There's in many communities, healthcare practices include scarification. In some communities, there's infant circumcision that's done by a traditional person. So that's not done presumably with the best sterilization or sterile technique. There appear to be a number of different mechanisms where within households, we have this horizontal transmission occurring.
Well, thank you. Thank you very much again to our audience and to Drs. Robert and Dr. Nguyen for the wonderful informative session and the great questions.
Thank you very much, Dr. Nguyen and Dr. Roberts, and thanks to you, the listeners, for joining us. As a reminder, to view the full program, Tackling Racial Disparities in Care for HIV and Viral Hepatitis, and to download the slide set associated with this discussion from the Clinical Care Options website, please click on the link in the show notes. As always, thank you for listening.